darnos su conferencia magistral, Pólipos colónicos, identificación, descripción y resección, que va a ser un complemento ideal para la plática previa de colonoscopía segura. Jonathan, muchas gracias.
Thank you again. I see the timer. I think I get 30 minutes, not 20. Is that right?
Yes.
Just wanted to be sure. Well, as I said, it is great to be in your country, and I always enjoy Mexico for so many reasons, and appreciate everyone's hospitality. This talk is going to focus a lot on how to identify polyps, dysplastic polyps, and then also how to properly resect them. So polypectomy effectiveness, it's interesting. Up to 27% of interval cancers may be due to incomplete endoscopic resection, as we heard earlier. And in the CARE study, there were high rates of incomplete hot snare resection. There was significant variation among endoscopists, and serrated polyps were 4 times more likely to be incompletely resected. And other studies have raised issues with effectiveness of resection with a biopsy forceps. And so for that reason, it is so important to be able to identify polyp types. And so when you think about that, there's gross morphological criteria, there are advanced imaging techniques, and then I'll speak briefly about artificial intelligence. But when it comes to gross morphologic type, the classic is the Paris classification. And what's more important is if you see, you can see that there's polypoid, non-polypoid, and then excavated. But the Paris 2C lesion, which you see the writing on the right, although it's uncommon, the risk of submucosal invasion is the highest. It's reported to be between 27 and 35.9%. And more than 40% of small depressed 2C lesions contain submucosal invasive cancer. And so that 2C lesion is something that you really want to understand. And usually you can identify it by adding some kind of dye. The other point that I want to make is as you're looking at morphologic criteria, you should understand lateral spreading tumors, which are those that are larger than 10 millimeters. There's low vertical growth and lateral expansion. And the key thing is to understand the types, because if you have a granular type and it's homogeneous, the risk of cancer is very low, and you can easily remove those piecemeal or in block. But once you get to the mixed nodular type, nodules greater than 20 millimeters can have a 38% risk of cancer. And then the non-granular type, which is a very smooth surface, those have a higher risk of cancer. So it's important to understand granular versus non-granular when talking about lateral spreading tumors. Now, there is a caution, though, when you use the Paris classification, and that in this systematic review, using gross morphology alone resulted in lower accuracy than optical diagnosis with image-enhanced endoscopy in terms of predicting submucosally invasive cancer. So if you find a lesion with high-risk gross morphology, it really requires an inspection with then image-enhanced endoscopy. So let's talk about image-enhanced. There are different advanced technologies. There is high magnification, there's virtual chromoendoscopy, or laser-based imaging. And so, for example, we use mostly narrowband imaging. And what narrowband imaging does is it enhances the vessels, as you can see there, and really gives you a great look at the surface and to detect dysplastic tissue. But when you look at serrated polyps, for example, this picture shows white light versus NBI. You can use NBI. It's not bad, but it doesn't always give you the clear margins. Whereas if you use an injection with a dye, we usually use saline and indigo carmine. This is methylene blue. You can see how you get nice documentation of the boundary. The other thing that's important to understand are the different techniques to look at the pit pattern. The most common is Kudo pit pattern, which uses magnifying endoscopy with dye-based chromo. More recently, again, as I said, we're using mostly NBI. And if you have that type 1 or 2, that's normal or hyperplastic or serrated polyps there. The type 3L and 4 are adenomas, and you can see those tubular features. The type 3S and the 5 are high-grade dysplasia or superficial cancer. And then type 5 is more deeply invasive cancer. And in addition to that, we use the NICE classification. There's the type 1. It uses color, vessels, surface pattern, and to predict pathology. Type 1 is, again, hyperplastic or sessile serrated. Type 2, you can see thick brown vessels and then tubular structures, and those are adenomas. And then the type 3 is areas where it distorted and suggests deeply invasive cancer. But the shortcoming, and you can see that the negative predictive value on the right is 95%, but the shortcomings are the inability to distinguish low-grade dysplasia from high-grade dysplasia with submucosal invasion, and it doesn't distinguish between hyperplastic and sessile serrated. And by the way, this shows an advanced lesion. You can see the disarray there that suggests submucosal invasion with that irregular microvasculature. And so it's recommended that you use this JNET classification. And what it does is it added, and the reason for that is that it created a 2B from the NICE classification of type 3. And the advantage is that it improves overall high confidence rate of predicting submucosal invasion, and it's able to differentiate low grade from high grade mucosal invasion versus deeply invasive. And so it can determine whether or not you do EMR versus in-block resection. And then briefly, artificial intelligence, we all know it has the potential to improve adenoma detection rate, and maybe we will be able to use it to determine whether or not we resect a polyp or not. And there's computer-aided detection, CAD-E, versus a computer-aided diagnosis. And you can see under the computer-aided detection that for particularly patients, doctors with low ADRs, it can improve the sensitivity and specificity of polyp detection. And in addition, the computer-aided diagnosis may allow us to determine whether or not we should even resect a polyp at all. So in a practical sense, what do we do? And this sort of is a summary of what I just talked about. You have to remember that if you're going to resect one endoscopically, you really want the dysplasia to be limited to the mucosa and superficial submucosa, less than 1,000. If suspected deep submucosal invasion, then you want to tattoo it 3 centimeters distal to the lesion and refer to an expert for resection. And part of that endoscopic characterization is using high definition and white light to differentiate conventional adenomas versus serrated lesions using the size, shape, mucosal pit pattern, and vascular pattern. And then that macroscopic characterization using the Paris classification, remembering that 2C and 3 are high risk for advanced histology. And then those flat lesions greater than 10 millimeters, the lateral spreading ones, you have to know that the granular one is low risk versus the non-granular that's high risk. And then you can use the microscopic characterization with NBI, NICE, and JNET for further classification. Now moving into polypectomy, And we're mainly talking about resection of polyps less than 10 millimeters, which are 90% of the polyps. And in most cases, and when it comes to cold forceps, I don't use it very often, but you can use it when the polyp's inaccessible for efficient snaring. It's associated, though, with high rates of incomplete resection. And for me, I think it's best used for polyps less than 3 millimeters, where you can grab the whole polyp at one time, and it's best to use the jumbo or large capacity forceps. Regarding hot biopsy forceps, when I was a fellow, we were using these, but it's associated with high rates of incomplete resection. It's been associated with a higher complication rate, and generally we're not using that anymore. But if you have a polyp like this, very small, and it fits into the jumbo forceps, and you can get it all in one grab, I think it's very reasonable to do that. But once you have to go for 2 or 3 more grabs, I don't think it's worth doing. Now, resection of polyps, and now for non-pedunculated polyps less than 15 millimeters, cold snaring is the preferred technique. It's less risk. You can perform it during the insertion phase. It's safe in patients taking antiplatelet agents or even therapeutic anticoagulation. It allows for immediate visualization of complete resection, and you don't have to use saline injection. And the technique is usually to use a small, stiff wire. You want to ensure about 1 to 2 millimeter margins of normal tissue. The snare sheath should remain embedded in the colon wall during closure, meaning that you don't lift it like you do for hot snare. And then be prepared to see a submucosal cord, which doesn't require treatment. And this gives you an idea. This is a relatively small polyp, but you'll see that when you put the snare out, you really want to depress it into the mucosa, and you want to make sure that you grab normal tissue underneath it so that you get the entire polyp. That's very different than the hot snare technique, which we use less and less, where you do grab the base of the polyp, but in this case, you lift and then use the cautery, and usually you can get a good burn and get all the tissue. Talking about electrocautery, the reason we use it is that it ensures hemostasis while providing thermal ablation. We recommend a microprocessor-controlled electrosurgical generator because it delivers alternating cycles of high-frequency short pulse cutting with more prolonged coagulation current. And the optimal choice depends on the polyp. We use coagulation, the pure power coagulation for pedunculated lesions, and then the blended current is ideal for non-pedunculated lesions. And this gives you a little bit of a summary. So on the upper left for sessile ones, you can see you can use that blended technique, either endocut or the cut coag cut, and that's the yellow pedal. Whereas on the lower right, for large pedunculated polyps, that forced coag is ideal using the blue pedal. And when you want to, from a general standpoint, it doesn't matter that much which you use, because in this large randomized trial at the bottom, you can see there was no difference really in complications or resection rates, whether you use the yellow or the blue. So I think it's also what you're most comfortable with. For those pedunculated polyps, though, it's usually performed with a hot snare. You try to position the scope so that the polyp is hanging down, and position the snare around the stalk 1/2 to 1/3 the distance to the colon wall, because you want to leave sufficient stalk to re-grasp it if it bleeds. And then once snared, the lesion should be lifted away from the colon wall and use, as I said, forced coagulation as ideal, particularly if you're worried about large vessels. And for very large lesions, you want to make sure that you minimize contact with the opposing wall. So in this case, you've got this large pedunculated polyp, and we rotate the patient so that we can get, in the best case scenario, get the polyp hanging down, and then you can easily get to the base and then appropriately cut it. Now, for large peduncular polyps, meaning heads greater than 20 millimeters or a stalk greater than 10, they're often fed by large vessels. So you can use other strategies, looping technique, the endoloop, clipping, volume reduction with epinephrine or forced coag. And this is an example of using the endoloop. And this is what I've used most commonly, which is easy to use. You put on the endoloop and tighten it, and then you can go above it and then do the snare polypectomy, and the chance of bleeding is much less. The other option here is using clips first before you make the cut. That's another way to do it. What about prophylactic clipping? This was a meta-analysis of 9 randomized studies, clipping compared with no clipping, and it didn't reduce the overall risk of post-polypectomy bleeding. Clipping significantly reduced the risk of bleeding after removal of very large polyps or those in the proximal colon. So the routine use of clipping isn't recommended, but prophylactic clipping could be considered for, again, removal of large proximal lesions. What about sessile serrated? They likely also contribute to interval colorectal cancer, as you heard before. They tend to be flat, subtle lesions with a mucus cap. Incomplete resections are high. And so optimal resection techniques haven't been established, but we think that you can still use cold snaring for these lesions if they're less than 20, EMR for larger lesions. Again, as I showed you with the injection, it's good to delineate the margins prior to resection, and you can use image techniques that can help. We most commonly use submucosal. We use dilute indigo carmine in saline. And then when it comes to inject and cut MR, you can do it with or without electrocautery. You want to bring the lesion to the accessory channel at 6 o'clock is the ideal position. You inject with fluid with the contrast agent as necessary, and lesions less than 20 can be removed in block because it's lower recurrence rates. Lesions larger than 20 usually require piecemeal resection, and then again we recommend a stiff snare where you capture the lesion with the snare, insufflate the lumen, then the snare is lifted up, and this is a subtle thing, but you want to slightly loosen it if you're concerned about any entrapped muscularis propria, and then prefer, a predominantly cutting current. You can use then the small snare to remove peripheral adenoma, or you can use a hot avulsion technique, and you can apply APC or snare tip soft coagulation to the borders as indicated. And then if you do a piecemeal resection, you want to follow up at 6 to 8 months. And this gives you an idea of inject and cut EMR, where again you inject, we usually inject saline. Oftentimes we'll add indigo carmine so you see the borders clearly. And then once you've injected it and you made sure there was a good lift, then you can put the snare around it. If you're worried about muscularis caught in there, you can loosen it a little bit and jiggle it so that you don't catch any of the muscularis. And then you can use the snare and safely cut the lesion off. But I mentioned about the non-lift sign because on the right you can see if you inject but you don't get that easy complete lift, then you have to be worried about invasive neoplasm or submucosal fibrosis. And then when do we use in block polypectomy? Again, that's ideal for lesions with a higher risk of submucosal invasion. Recurrence after colonic EMR ranges from 10 to 30%. It's higher with piecemeal resection, and it recurs, as I said, a structured surveillance program. Now, this is not something I do, but my colleagues. This is courtesy of Norio Fukami. But you can see how, again, you want to make sure you get a good lift. And if you are confident, about that, then these lesions are relatively safe to take out, once you've lifted enough above that muscularis mucosa and can safely remove the lesion. If you aren't going to remove the polyp, and that happens sometimes, all of us, make sure you tattoo. You use the PPD technique where you approach tangentially and lift the needle. You don't have to tattoo in the cecum. We like to inject 3 centimeters distal to the lesion in 3 or 4 quadrants, and say exactly where you place the tattoo in your report, and then also report on any other tattoos seen for the surgeons so they know that there might be other tattoos seen. There's also underwater EMR, which you saw previously, and it facilitates mucosal and submucosal floating and akin to submucosal injection. So it implies electric artery without injection. You don't have to inject usually. And it may be particularly beneficial in patients with submucosal fibrosis. And a recent study showed that underwater EMR is faster, achieves low incomplete resection rates, and avoids submucosal injection with potential cost savings compared to conventional resection. And then, if you're going to do this, then you want to be aware of the complications. The biggest one is post-polypectomy bleeding, and it can be intraprocedural delayed. It occurs up to 11% during EMR like this. It's usually treated with snare tip soft coagulation, but you can also use clipping. And, most of the time you can take care of this, and particularly in post-polypectomy bleeds, we'll almost always clip. And the other one on the right is the target sign. That's where you did, in fact, catch muscularis, and this could be an indication of delayed perforation. And so in this case, you want to clip. It occurs in 1 to 2%, but you want to be aware of that target sign. So this is a nice summary of the approach to endoscopic lesions in general and the subsequent treatment approach. So you want to have a systemic lesion assessment. You want to determine the size, and I usually use either the sheath of the snare or biopsy forceps to determine the size. You then want to determine the Paris classification, or if it's a lateral spreading tumor, whether it's granular or not, and then look at the surface pattern with high definition electronic chromo. Once you've done that, then you want to move to the morphology, and that you're mainly doing that to look for submucosal invasion. So you're going to use the Paris classifications, and remember that the 2C and of course the 3 are related to advanced disease. The non-granular lateral spreading tumors are the ones, if they have a dominant nodule, have a higher risk of cancer. Then you look at the Kudo pit pattern and the NICE. And you're specifically looking for morphologic features such as spontaneous bleeding, fold convergence, redness, sclerous wall changes, white spots, or exudates that might indicate submucosal invasion. And so on the left there, if you suspect non-invasive or superficial submucosal invasion, that's where you probably want to send it to an advanced therapeutic endoscopist. It's not something I would do, and they would do usually an en bloc resection with EMR or ESD. You can do piecemeal resection if en bloc resection isn't feasible, and then of course if they're very large, you may need to send to a super expert. Once you suspect deep submucosal invasion, then you want to do a confirmatory biopsy, refer for surgical resection, and I said, always place a tattoo adjacent to the lesion. And I hope that was helpful to all of you, and thank you very much.
Please join us. Tenemos tiempo para preguntas y respuestas.